Insulin's pushing harder, it's pushing harder, it's pushing harder, but at some point it reaches its limit, and then no matter how hard insulin pushes, you can't shove any more glucose into that cell, and therefore that's when the glucose winds up in the blood, and then you get diagnosed with type 2 diabetes. But the process has been going on for a long time before. The problem is not really insulin. The problem is that you really have just too much glucose around, so the solution, of course, is to get rid of some of the glucose. You can get your sugars down into the normal range, so therefore you can reverse your type 2 diabetes. So that's what we should be aiming for.
Jason, in the new book, you use this really great analogy of a sugar bowl. And I think it'll be helpful for all of us to get on the same page to understand insulin resistance and type 2 diabetes, that whole spectrum there. So I'll have you explain how that works.
Yeah, so the body has a certain ability to store energy in the form of sugar. So essentially, if you think about a sugar bowl, that's what it does too, it stores sugar. But once you reach its capacity, it sort of, bulges over and then it spills out. And then when it spills out, then you get it on the floor, and that's when it becomes a problem. It's not a problem as long as it stays in the bowl. It's much the same as the body. So the body can also store sugar. And by sugar, I mean not just sugar like sucrose, which is table sugar, but sugar in terms of glucose. So most starches are glucose, blood sugar is blood glucose. So bread and rice and potatoes, they're actually long chains of glucose. So the body can store glucose for energy, and when you eat, you'll store some of the sugar. When you don't eat, you're going to use some of the sugar, and that's why you don't sort of die in your sleep every single night. However, if you exceed the capacity of the body's ability to store that glucose, then it's going to overflow into the blood. And then when it overflows in the blood, then they say your blood sugar is high, and then that's when you get diagnosed with type 2 diabetes. So essentially, the problem with type 2 diabetes is that your body simply has too much glucose, such that it's spilling out into the blood, and then that's how it's detected, and that leads to many problems down the line. So understanding that makes it easy to understand why diets, such as cutting down the carbohydrates, which is reducing the amount of sugar you're putting into the body, or intermittent fasting, which is allowing your body to burn off some of the sugar, can be very effective for reversing type 2 diabetes.
So taking our analogy there, the sugar bowl, translating that to the body, what specific tissues, organs, cells are we talking about that are becoming full of the glucose?
Basically, all of the tissues in the body get affected. So unlike most other diseases, diabetes affects everything. So it causes heart problems, causes strokes, causes cancers, causes blindness in terms of eye disease. It causes nerve damage. It causes kidney damage. So pretty much causes liver damage. So pretty well every single organ you can think of in the body is affected by diabetes, because every single cell is sort of overflowing with this glucose. You also in diabetes see these weird infections that you don't get otherwise, like diabetic foot infections and weird fungal infections. And that's because the tissues of the body have so much sugar, and the bacteria really love it, so that they can thrive much more easily when there's all this sugar available to them.
Let's talk about the period of time before diabetes strikes in full force. And that's the continuum, the part of the continuum of insulin resistance. So we can talk back to what you explained before, the fact that somebody is having these carbohydrates or sugars, the body is trying to compensate and bring the blood glucose down by creating more insulin. Talk about that period of time that can even be up to a decade, where the body is compensating for this extra glucose, trying to store it away, and over time what happens and what breaks.
Yeah, so insulin resistance is a term that's used because the blood glucose goes high and the body doesn't like it so high, so it makes more insulin to sort of allow it to go in. So one of the actions of insulin is to allow glucose to go from the blood into the cell so that the cell can use it for energy. Insulin resistance is a term that they use when they say, oh, well, there's lots of glucose in the blood, and there's lots of insulin, so why is it not going into the cell? So they say the cell must be resistant to to the effect of insulin. And you can think of it like, suppose you have a restaurant, and you have the doors, and the doors open and the people go in. So that's what's normally supposed to happen. If you see a big crowd of people on the sidewalk, it could be that the door doesn't open, and that's the situation in type 1 diabetes, for example. There's no insulin, so then the door doesn't open, and therefore all the glucose, all the people stay outside. In type 2 diabetes, they imagine a very similar situation to this where there is lots of insulin, but for some reason the insulin is not opening up this door and allowing the people to go in. There's a big problem with this idea, which is one that most doctors still consider to be the way that it works, is that if you think about that restaurant, if the people can't get in, then inside the restaurant it must be empty. So if you translate that to the body, you have a cell. The glucose is outside in the blood. It can't get into the cell. The cell inside should be very empty. And therefore, if the cell has no energy inside, people should be very skinny. They should be very thin. They should have very small, shrunken livers, not big, fatty livers. But in fact, you see the opposite. You see people who are overweight, who have big, fatty livers, and so on. So the cells are not sort of starving. They're sort of overflowing. So if you think about that situation in the bar, there's two possibilities. Either you have a problem with the door, or it could be that the door is wide open, but the restaurant's sort of already completely full, such that you can't push any more people inside. And in that situation, you're still going to have lots of people outside because you can't see inside the restaurant. You can't see what's happening in there. So that's an overflow situation. So I think this is what's happening in type 2 diabetes, which is that the cell really has so much glucose that it can't get rid of, it can't let any more of the glucose into the cell, even though there's plenty of insulin. So the problem is not really insulin. Insulin is doing what it's supposed to do. The problem is that you really have just too much glucose around. So the solution, of course, is to get rid of some of the glucose.
And for a period of time, this works where the body is making more insulin and continuing to drive that glucose out of the bloodstream into cells. And then eventually that whole system breaks, insulin dips, and then blood glucose rises.
Yeah. So for a certain period of time, you can sort of brute force it, right? You can take the people and just shove them with extra force into that restaurant. And then it looks like everything's fine, but the problem is that you've had to use a lot of extra, pushing to get those people inside. So in the cell, what you see is that the glucose has been shoved into this overstuffed cell, right? The cell is stuffed with glucose, but you used extra insulin to really shove it in. So the glucose is normal, but the insulin levels are high. So you know something's not right in this situation. You have hyperinsulinemia, which is where hyper means too high, insulin is, the hormone, and emia means in the blood. So you have too much insulin in the blood. Even though your glucose is normal, you see this hyperinsulinemia much, much, much before you see the increase in glucose. It's only when that sort of, when insulin can no longer, you can't produce enough insulin to shove all the glucose in, that you start to see the problems. So it's sort of like if you have, a luggage, right? You put the clothes in, it goes in fine. Once it gets full, it's hard to put those clothes in and close it. You can, start pushing harder and harder and harder on it, but at some point it's going to stop. And that's what's happening with insulin. Insulin's pushing harder, it's pushing harder, it's pushing harder, but at some point it reaches its limit. And then, no matter how hard insulin pushes, you can't shove any more glucose into that cell. And therefore, that's when the glucose winds up in the blood, and then you get diagnosed with type 2 diabetes. But the process has been going on for a long time before that.
And here's where a big part of the problem lies, what you just touched on there, the fact that this goes on in the background for a period of time, and where the whole quote-unquote mistake is happening is the fact that doctors are typically looking at blood glucose and measuring that. So we're looking at the wrong thing, which, coming back to what I said before, we only see that rise once insulin eventually dips after the system's been being trashed for years and years.
Yeah, exactly. So The whole diagnosis of type 2 diabetes sort of hinges on seeing that extra glucose in the blood, but that's a very late stage. It's, sort of 10, 12 years after what's going on has been a problem. And that's, that's based on sort of a sort of old concept of what type 2 diabetes is. There's this concept that a lot of people had mistakenly thought for years that it was the high blood glucose that was causing all the problems rather than the sort of overflowing cells with glucose. So if you have cells that are overflowing with glucose, as long as the blood is normal, there's a feeling that, hey, it's all fine. But it wasn't fine because you had all these other problems going on in the background that weren't being taken care of. So the idea is to try and figure it out at an earlier stage, but also to use, if you're trying to get rid of the glucose, for years there was no good drugs that could do it. There are some now, but the older drugs like the insulin, the metformin, the sulfonylureas, they weren't effective at getting rid of the glucose, and therefore they didn't actually change the underlying problem with type 2 diabetes.
If you're enjoying this episode with Dr. Fung, let me know by liking and subscribing below. Thank you so much. And for somebody who's tuned in thus far and they're saying to themselves, okay, maybe I'm in that big latent stage of even up to a decade or more where I'm starting to become insulin resistant, but I don't have full-on diabetes. How does that person begin to understand where they fall in that continuum and whether or not they need to make changes to their diet and lifestyle?
Yeah, you can look at a few things. So the metabolic syndrome is this cluster of sort of 5 things that all go together with high insulin levels. So you have the high blood sugars, of course, that's very late, but you have also high blood pressure. You have a high triglyceride with low HDLs and abdominal obesity. Of course. So you can measure, they don't actually use body mass index, which is very common for people with weight problems. They use abdominal circumference as a sort of proxy because you tend to store fat for metabolic syndrome more in the abdominal area rather than sort of all around. So the whole idea is that you can look at any of those 5 manifestations of hyperinsulinemia or the metabolic syndrome, and that'll give you a clue because not all 5 necessarily are going to be there. So you could have, say, just high blood pressure and all the other 4 are negative. That could still be a manifestation of hyperinsulinemia, or you may have high triglycerides and low HDL, or you may have just the abdominal obesity. So you can pick that up earlier. You can also use fasting insulin levels and things like that, although that's not typically done as much because there's a lot of variance in the insulin levels. Just like glucose levels, it goes up and down sort of every minute of the day.
Let's get into some of the details of the different health problems that occur along that spectrum of insulin resistance all the way to type 2 diabetes. And to me, there's 2 different issues happening here. One being the increased insulin, and 2, which can be compensated by the increased insulin at times, is the blood glucose. So when it comes to the array of different, you talked about early on the fact that this is affecting everything in the body, but how much of it is because of the insulin, and then how much of it is blood sugar that's not being controlled? And then specifically, what are the challenges under those umbrellas?
It's almost all due to the insulin, really. The high blood glucose is sort of a downstream problem of that. So we had in the early 2000s several very big, expensive trials where they took people and they basically said, we're going to drive your blood glucose to as low a level as possible by giving you mostly like things like lots of insulin. So essentially, if you think about it, you have this cell that's sort of overfilled with glucose, right? And you're giving a lot of glucose to make sure that the glucose doesn't stay outside and you're shoving it inside. And they thought that that would be very beneficial in terms of reducing heart attacks and strokes and all this sort of thing because the glucose in the blood was normal. they moved all that glucose into the cell, right? So people were gaining weight like crazy, because all that glucose in the cell, the body can change that into fat. So even while they were making the blood glucose very good, they were making the actual diabetes worse because the cell is just super ultra full, right? So the whole point is that when they took a look at those results, lowering the blood glucose to near normal levels didn't actually make anybody better. In fact, it might have been actually quite harmful. One of the studies showed an increased death rate, so it wasn't good at all. So most of the effect of the type 2 diabetes really is the insulin, which is reflective of the sort of glucose in the whole body, not just in the blood, right? The blood is only one component of the body. There's also the rest of the organs and inside the cells and so on. And there's just glucose sort of everywhere in there. And just taking it out of the blood and shoving it into the liver doesn't really help. You're simply moving around the problem of the excess. Sort of like if you have garbage and instead of throwing it out, you just put it under the sink and keep putting it under the sink. Well, you can't see it anymore. So you think you're doing great, but it still smells. So it's just like that glucose, right? You keep taking that glucose and instead of getting rid of it, you just shove it into the liver. Well, eventually it causes more problems because you actually haven't done anything about the excess. The excess is still around. The minute you stop taking that insulin, all that sugar just comes, rushing back out because, you haven't gotten rid of it.
So we've uncovered the fact that insulin is the main problem here. When along that spectrum of insulin resistance do people start having issues with chronic disease? I'm sure it's going to depend on the person, their genetics, a lot of different variables. But what I'm getting at here is how long or how often actually do people have a chronic disease in that period before type 2 diabetes strikes?
It can be long. I mean, the whole transition can take, 10, 15, 20 years, which sounds like a long time, except that a lot of people are developing type 2 diabetes now in their childhood because of dietary issues. So we see, it used to be if you had diabetes as a child, it was type 1 diabetes. Now it turns out that there's a lot of type 2 diabetes as childhood obesity has sort of exploded, sort of thing.
But it doesn't take pushing it all the way to diabetes, whether it be an adult or child, to start suffering from chronic disease, correct?
Yeah, you can start getting it fairly early. It's sort of like a good news, bad news thing. That is, if you pick it up, you can catch it early on, right? If you know about it, you have a long time to sort of deal with it. On the other hand, once it develops, it's really hard to reverse. So that's really one of the problems. So it can start, very early within a few years. This is so from the process happening. That's not from when you make that diagnosis. That diagnosis can stay hidden for a long time. Like if you don't do your blood test, if you don't do your, if you don't, check your waist, your weight, your blood pressures, then it can be a long time before you pick it up. Like you may have had it for some people may have had it for 10 or 15 years before they pick it up and then have already had the chronic diseases starting to take hold. So I see this a lot actually. So one of the places that you can see it relatively early is you can see it in the urine. So I get referred a lot of people with protein in the urine, and one of the things that is happening is that they're starting to get this diabetic damage to their protein. So that we see this protein sort of spilling out in the urine, and that's the first sort of thing that is noticeable. They don't even know that they have diabetes. So certainly you can see the damage, before you have the diagnosis. But, if you were to look back in time magically somehow, you would still see that actually had happened things had happened a long time ago. You just didn't know about it. So on the one hand, there is time. On the other hand, you have to really be aware of it and looking for it.
And whether or not somebody knows that their insulin's elevated, most likely they won't know unless they're tuning into something like this and having their fasting insulin tested. But what I'm curious about is the more serious health conditions that happen before even diabetes can strike due to that chronic insulin being produced en masse in the body.
Yeah, for sure. I mean, I see people with diabetic kidney disease that don't even have diabetes. And it's because metabolic syndrome, of course, is this constellation of 5 things. So you may not have the diabetes, but you may still have this associated, we call it diabetic kidney disease, but it's actually metabolic syndrome associated kidney disease. So it certainly can happen early, and that's why you always have to be on the lookout for it. Once it develops, it's really hard to sort of go down.
But what I'm getting at there is there can be even things like heart attack and stroke, cardiovascular disease from the insulin being chronically elevated.
Oh yeah, insulin is actually well known, and I don't know why people don't sort of clue on, but insulin's actually really, really well known to have pro-atherogenic effects. That is, it causes the hardening of the artery, the narrowing, all of those things. So the process of developing a heart attack is because you get a narrowing in the artery of the heart in the brain. It's a stroke. And everybody assumes that it's because cholesterol basically clogs up your artery. That's probably not true at all. And even when I was in medical school 30 years ago, we talked about this. And it's that idea that you're just clogging up the artery with cholesterol is completely wrong. I mean, they taught us that in 1990. So this is, 30 years later. I don't know why we still talk about clogging up the arteries with cholesterol. But essentially, what they're saying is that the reason these arteries get blocked is not because they get clogged with cholesterol. It's a response to injury hypothesis. That is, there's an injury to the endothelial cell, which is a cell that binds the artery, and then you get things like smooth muscle proliferation. And then from that, you get infiltration into the artery from this cholesterol. But the inciting incident is really an inflammatory response. It's this sort of idea that it's the inflammation and it's the smooth muscle proliferation that's the problem. And insulin's well known to contribute to all of those things. So I'm not sure why we're so sort of fixated on cholesterol. I mean, sure, it could be one of the factors, but it's not a major factor. I mean, look at the major factors of heart disease, right? Cholesterol is not even close. Smoking is way worse, and diabetes is way worse. I mean, there was just a study like a week ago, looking at the effect of various risk factors and so on, and by far and away the two most important things, especially in younger people like 50 or less, is smoking and diabetes. Like cholesterol didn't even make a dent. It was the risk of so diabetes sort of either double or tripled your risk of heart disease, whereas a high cholesterol didn't change it barely at all. Smoking did the same. It sort of doubled or tripled your risk. So very interesting, because those are not cholesterol-based things. They're inflammation, insulin. There are lots of studies on other treatments, such as like colchicine, which is an anti-inflammatory, which may be very useful in the treatment of heart disease, that have nothing to do with cholesterol. So we're so sort of focused on the cholesterol that we're sort of missing all these other things that we know about, because smoking doesn't raise your cholesterol, right? It has all sorts of other bad effects, but cholesterol is not one of them. So for all those people that sort of say, oh, it's all about cholesterol causing heart disease, like, no, there's like a ton of other issues. Cholesterol could be an issue, but there's a lot more important issues, diabetes being one of them by far and away. And nobody talks about that. High insulin is one of them.
We keep hammering home this point that there's this period of time, this latency before type 2 diabetes fully manifests, where people are insulin resistant, insulin's chronically elevated. As you're explaining there, it gets me curious thinking about people that have heart disease before diabetes versus after. Like, how many people within that decade of insulin resistance before they were even diagnosed with diabetes have heart disease versus somebody who's way down the line and has been suffering with diabetes? You probably don't have an answer to this, the percentage wise, but do a lot of people end up having that heart disease way before diabetes even strikes?
Well, there's a lot of different things that cause heart disease. I'm sure it's a continuum. That is, there's different. Some people it's going to be a minor contributor, and other people it's going to be a major contributor, right? But there's other things like age and sex and genetics and exercise and smoking and cholesterol and there's just this whole other issues, right? So if you look at risk factors for heart disease, there's a whole bunch of different things. So I'm sure that diabetes contributes. It's a major contributor for sure, but in any particular person is going to be that combination of things, right? So men tend to get it younger than women. Women are protected until they're postmenopausal, for example. So there's all these sort of different things that go on that contribute. And for each individual person, it's going to be variable. But for sure, diabetes could be one of the major contributors. And the important thing about it really is that it's a reversible risk factor, right? So age is probably more important than anything else, but you can't do anything about that. So, and same with genetics. Genetics is probably much more important than any of the factors we talked about, but you can't do anything about it. So why worry about it? You can't, you can't change any of that. Whereas smoking, for example, you can change. And diabetes, which was considered not reversible up until sort of like a year ago, which is sort of blows my mind, right? This is what I wrote about in the diabetes code, is that it's unbelievable that every doctor considered type 2 diabetes as a chronic and progressive disease when we know that it's actually reversible. You can get your sugars down into the normal range, so therefore you can reverse your type 2 diabetes. So that's what we should be aiming for. And people were like, oh, no, that's not possible. I was like saying, that's a complete lie. So I wrote that the book was published in 2018. I've been writing about it since like 2013. So 10 years ago, and it wasn't until 2021 that the American Diabetes Association put out criteria for remission, basically admitting that it's a disease that can be reversed. And the Canadian Diabetes Association didn't put that out until this year. It's like, the fact that they couldn't see what was sort of super obvious, that you need to get people to change their diet, to lose weight, to reverse that diabetes. Like, everybody with any type of logic could see that was true, and yet they were denying it, right? These are the doctors and the specialists, right? So it's sort of mind-blowing that that these sort of, conventional specialists were so, blind to the fact that you could actually reverse this disease.
Well, we're going to get into the specifics of how people can do that, how they can lose weight. Coming back to our sugar bowl, how they can start dumping out that sugar in the body that's been accumulating. But before we do that, I want to make sure I tease out the point I was trying to get at, where people might not get to the full stage type 2 diabetes. And the way I understand it, and I'll have you clarify, is they could still have heart disease or stroke in that period of time where they're just insulin resistant.
Yeah, absolutely. So the point is that the disease of the hyperinsulinemia goes way, like, a decade or more before you actually get the diagnosis of type 2 diabetes. So therefore, that period of time where you're still hyperinsulinemic, that insulin is still contributing to the development of the atherosclerosis, which is the hardening of the artery, the narrowings, and so on. So it's not as bad as if it was type 2 diabetes, but it's actually starting in that period. So you don't have to have diabetes. You're getting a contribution from that hyperinsulinemia long before.
And part of the scariness of that situation is people, when they're insulin resistant, they might not actually be overweight or obese. there's a certain group of that population that will appear skinny and still be suffering from increased insulin on a chronic basis, like we're talking about.
Yeah, absolutely, and that's the thing about the body mass index, which is a little bit deceiving at times because it only takes into account height and weight, for example. If you have very high muscle mass or very low muscle mass, then of course that weight is going to be not a very accurate reflection of body fat versus lean mass, sort of thing. So it's definitely one of the things that you do have to sort of make sure that you look at in a little bit more detail than just say you were skinny. And I remember looking at data a while ago in China. They have a lot of type 2 diabetes now, and their average body mass index, I think, of people getting the diagnosis was like 24.3 or something like that, which is, if you look at the body mass index, under 25 is considered normal weight. So these are all, on average, normal weight people by body mass index that were getting type 2 diabetes. Right, that's sort of scary. In the United States, it was closer, I think, to 27 or 28. So people were overweight when they got the type 2 diabetes. Whereas in China, for example, they get at much lower body weights. I think for South Asians, that's true as well. So they typically they don't look like they should have type 2 diabetes because they look relatively okay, but they still have it.
I want to come back to what you just said there when we get into treatment, because this is one of the questions that came up on some of our previous chats. People were wondering if they're type 2 diabetic and they weren't overweight, how they go about addressing things. But we're going to put a pin in that for later when we get into treatment. The last piece of the story I want to address before we get to treatment is the piece of the liver and pancreas. So talk about how over time, as again, we're going through this continuum of insulin resistance and type 2 diabetes, they begin to accumulate fat and then the physiological changes that happen there in both of those.
Yeah. So if you think about this disease where you're just taking too much sugar, your body will store some of it, but when it gets too much, then what it has to do is it activates a process called de novo lipogenesis, which is de novo means from new, lipo is fat, and genesis is the creation. So it's the creation of new fat. Essentially, you're taking sugar, which is carbohydrates, glucose, and you're turning it into fat, and that's what happens. So your body protects itself, right? If it overloads, say you eat, a big plate of spaghetti, 3 times in a day, you've overloaded your body with a lot of glucose. But if you're relatively healthy, your body will simply turn some of that into fat, and you're still okay. The problem is when this goes on chronically, what happens is that your body takes the glucose, it turns it into fat, and then from the liver has created this new fat, right? That's the de novo lipogenesis, and it's going to shoot it out into the blood because it doesn't want to hold on to the fat. The liver is not an organ that's supposed to store fat, so it pushes it out as triglycerides. So triglycerides go up and HDL goes down. And then other parts of the body are going to have to take up the fat. So fat cells or adipocytes are supposed to take up the fat. But when there's a lot of it, then a lot of the abdominal organs and the fat around the abdomen start to take it up. And that's where you start to get the increased abdominal circumference. So you start to get that sort of big belly. And this is something that you do see in a lot of Asians. Because their muscle mass tends to be lower. Some of them are quite skinny looking, but then they have this large abdomen filled with fat. So they actually have a fair amount of this metabolic syndrome already happening. But you wouldn't know it just from the weight. You could only see it if you look at the distribution of that weight. So what happens is that the body's just trying to cope with all this extra fat. So eventually some of it just gets stored in the liver. You get this fatty liver. Some of it gets stored in the fat around the organs, which is called omental fat, and you get this increased abdominal girth. And then some of it gets deposited also in the pancreas, which you can also see in ultrasound. So people start to talk about fatty pancreas. So the pancreas, as it sort of gets filled with fat, eventually gets, so the insulin's going up and up and up as the pancreas is trying to deal with all the glucose. But when it gets all clogged up with fat, it actually starts to dip, and that's when you see the diagnosis of type 2 diabetes. So people used to assume that the pancreatic, when the insulin started to fall, that was the pancreas was burning out, but it wasn't really burning out. It was just clogged with fat. So if people lose weight, what you can show is that the pancreatic function starts to return as you sort of unclog the pancreas's fat. And you might ask, okay, so why does this happen? And the answer is probably that the body is extremely smart. So as the pancreas gets clogged up with fat, what happens is that the insulin starts to dip. The glucose in the blood starts to rise because the insulin is no longer able to shove all the sugar into the cells. As the insulin starts to fall, the blood glucose starts to rise, and then you start to pee out all this extra sugar because there's a certain threshold in the kidney above which you can't reabsorb the glucose. So you're actually starting to dump out this glucose into the urine. And so you might see it in terms of the symptoms. You see this excessive urination. You have a lot of thirstiness because people are trying to drink water because they're dumping all this glucose in the urine. But if you think about it, it was actually all a protective mechanism because the body sensed that there was just too much glucose. Your body's overloaded with glucose. So the solution it came up with is to slow down the pancreas and let it dump out all the glucose. Yes, you have other problems that go on when that happens, but it's a solution to the underlying problem of excessive glucose overall.
Up until this point, we've been focusing on type 2 diabetes. Coming back to our sugar bowl, the cell that is too full of glucose, and even with insulin, it's not going to allow more glucose in there. I think it'd be helpful at this point to talk about type 1 diabetes, which has similarities, but different mechanism. And the cell itself is actually starving in that case, just to give people the full picture and understand both mechanisms.
Yeah, so type 1 diabetes is completely different. So there's no insulin. So not that there's too much insulin, there's really just very, very little insulin. So if you think about what insulin does, it sort of opens that door so that glucose can go from the blood into the cell. When you don't have an insulin, that door is basically locked. So the glucose is in the blood, but inside the cell, you have no energy whatsoever. So you get small shrunken livers. People are emaciated. They actually have no body fat. They're skinny. They're just skin and bones sort of thing. And no matter what they eat, you can feed them as much as you want, but the glucose can't get into the cell because that door is sort of locked. So they just waste away. You could feed them 10,000 calories a day. It wouldn't do anything because it can't get into the cell where it's supposed to go. So that's where a situation where you actually have internal starvation, and people will die until you give them insulin to unlock that door so that people can get the glucose can get into the cell. So to provide it with the energy that it needs. So that's a totally different situation where you actually have too little insulin, which is almost the polar opposite of type 2 diabetes where you have too much insulin. So if you have too much insulin, then the solution is to lower the insulin, which is by intermittent fasting, low-carbohydrate diets, and some of the new drugs will do that too, compared to type 1 diabetes where you have too little insulin, in which case the answer is to give insulin. And of course, that's a life-saving drug in that situation.
Let's move into treatment. So coming back to our thesis here, the fact that cells in the body have extra glucose and we need to dump them. There's a couple different ways we can go about this. One is controlling the amount of glucose or carbs we're intaking. Two is fasting, which is going to allow the body to dump the glucose. So let's go into each of those to start and talk about practically how somebody can begin to reverse this.
Yeah, so there's actually multiple ways you can do this. So if you think about the sugar bowl, if you're putting sugar in, and your body will burn sugar for energy. Well, if you put less sugar in, then that's great because, you're going to have less sugar. Sugar bowl is going to go down. It's not going to spill out. So cutting down the carbohydrates is a very sort of easy and obvious way to get going. And in fact, it's extremely effective. So the American Diabetes Association says of all the diets, the one with the most scientific evidence is the low-carbohydrate diet. So there is no diet that has been studied more or has such good results as cutting down refined carbohydrates. So that's basically cutting down sugar, cutting down white bread, white rice, potatoes, and processed foods like that. So that is probably it's easy to understand because, if you think about it, there's this thing we use called the glycemic index, which is a index of if you eat a certain amount of food, how much your blood glucose goes up. And carbohydrates have the highest glycemic index of all foods, right? So if your problem is that your blood glucose is too high, then don't eat the foods that raise your blood glucose. It's sort of obvious. And so I don't know why it took, the American Diabetes Association, up until sort of 6 or 7 years ago to really understand, hey, we've known about the glycemic index since the 80s, because I learned about it again in medical school. So for 40 years, we knew that eating bread spiked your glucose, and we still told people to eat bread. It's like, how does that even make sense? Why would you eat the foods that are going to spike your glucose the most? And it wasn't until about 6 or 7 years ago when the low-carb movement really started getting going again that people said, hey, this is silly. You should just cut the carbs. And in fact, Dr. David Unwin, who's a physician in the UK, he does that for all his patients. He actually, of the people who follow him, about 50% go into a complete drug-free remission just from cutting out the carbs or cutting down the carbs. That is 50% of the people that he had in his practice that had diabetes, he turned them into not diabetic, right? They came off all their medications and their sugars were low enough to be classified as non-diabetic. That's insane. If you took all his patients, it's still about 25% because not all his patients followed, the diet. So extremely effective, well accepted. The consensus conference from the American Diabetes Association says, yes, you should try that. But there are other ways to do it too. You can do ultra-low calorie diets, for example, which is cutting down not just carbs, but everything, right? Because remember that your body can use sugar as a source of fuel. It can also use fat as a source of fuel. If you cut down all calories, and this is using extremely low calories, most of the studies that are effective are cutting your calories to about 800 calories a day. So really, really low. So if you don't eat a lot of fat as well, because fat's a source of calories but not glucose, then your body's going to have to take energy from somewhere. If it doesn't have fat, then it's going to start burning the glucose. So again, lowering that sugar bowl, right? Burning down that sugar. And it can also work. It's just not as easy. That's all. 800 calories a day forever, I don't think you're going to get a huge compliance with that. And then intermittent fasting is again similar. Instead of doing sort of very low calories all the time, like 800 calories a day, you do 0 calories for a certain specific period of time. And what you're doing there, of course, is allowing your body to burn off its the excess glucose. You're allowing it essentially to eat the glucose that you've stored up, because that's what it is. It's a source of energy. So if you have a lot of energy sitting as glucose in your body, then let your body use it up. It's no different than if you were to, you fill up your car at the gas station 3 times a day, and now the gas tank is full, but you still keep pumping it. Well, the gas is spilling out into your back seat. It's making you sick. Well, what do? Well, stop filling up. That's basically what fasting is. Stop filling up and let your body use up the glucose. So again, extremely effective if people will do it. But you have to tell people why they're doing it, what they're doing, and what they're doing it for, right? So again, another recent study from this year showed that if you put people on a intermittent fasting schedule, then they in their study, they put about 50% of their patients into a complete remission as well. So again, these are extremely effective treatments. There's multiple ways you can do it. There's there's not just one way you can do it. So there's multiple ways, because some people, say, oh, well, the vegans have this other thing, and the carnivores have this other. There's multiple ways to do it. I'm not saying that these are the only ways to do it. And the good news is that if it works for you, then it doesn't matter what works for anybody else. You do it. Like if you want to do ultra low calorie, 800 calories a day for the rest of your life, go ahead, do it. Like you could probably be successful in doing it.
Okay. So to highlight there, we have 3 different methods that you've given us: low carb, intermittent fasting, and cutting the calories. And I want to take some time and jump into each of these for some nuance. Let's talk first about the low carb piece. For somebody that wants to go low carb and use that as a tool to fight back against what we were talking about before, how low carb do they need to go to start? Obviously, it's going to depend on the person, how quickly they want to recover. But to give somebody a baseline to start, and you didn't mention the word ketogenic in there. So I'm curious, is ketosis part of this? Because those two diets are similar, but there is some nuance there.
Yeah, so ketosis is an ultra low carbohydrate diet. So if you think about how many carbohydrates most people eat, it's around 250 to 300 grams per day is sort of an average number that people eat. And that's based on the old recommendations where the American government said you should eat 55 to 60% of your calories as carbohydrates. So people are taking about 250 to 300 grams of carbohydrates, which is fine if it's all broccoli, but it's mostly like, bread and these other highly refined carbohydrates. If you go down to sort of a low carb diet, you're not in ketosis. But if you get down to, say, 100 grams a day, it's a significant decrease from, say, 300 grams a day. And for a lot of people with relatively mild disease, it's going to be enough just to reverse that whole thing, because they're used to putting in triple the amount of glucose into the body, and then if you cut it down to 100. But it's not low enough to get you into ketosis. Ketosis is a process where you have so little carbohydrates. So remember, the body has two sort of sources of energy. That's glucose and fat. If you have very little glucose or carbs, then your body will burn fat. And when it burns fat, it generates ketone bodies for the brain. And if you go below about 40 grams a day then you're into that sort of ketogenic diet thing. So you don't have to go into ketogenic diet to get good results. But some people like it because then you can measure your ketones, like in your breath and so on. So it tells them that they're sticking to the diet. So when they get into ketosis, they're like, oh, okay, I can measure it now, and therefore I can stay in it and see my progress. And because it's a stricter diet, it's going to give you better results, and it's going to give you better results for very low very, very severe disease. So there's a company that does that, tries to put people into a ketogenic diet for type 2 diabetes, and very successful at reversing it as well.
Okay, second tool you gave is dropping the calories. And I think you threw out the number, and I'm not sure if this is a specific number we need to follow, but 800 calories a day. And I know we've talked about calories in the past, and this one surprised me. I haven't heard you talk about it before, and I know you're not somebody that totally buys into the whole calorie thing. So talk more about why you're jumping onto this and the nuance there.
Well, calories. So there's several trials. Dr. Taylor in the UK has done several trials of ultra low calorie diets, and the thing is that the calories is just a measure of food energy, right? And so the problem is that people focus on it as if it's the answer, right? I mean, you've heard this before. People say it's all about the calories. It's like, no, losing weight is not all about the calories. It's about controlling the hunger that leads you to eat calories, right? Same with these weight loss drugs, right? Ozempic and Wegovy and all these drugs. They don't reduce calories. That's not their primary effect. Their primary effect is to reduce hunger, reduce appetite. And by reducing appetite, that's how you control the calories, right? So it's not that the calories are reduced. It's why the calories are increased. That's the problem. That's what you have to deal with. Just like saying, somebody who says, well, alcoholism, it's all about alcohol in versus alcohol out. And anybody who denies it is wrong, right? And it's like, that's not the issue here, right? So you can't just cure alcoholism by saying, just drink less alcohol, which is this exact same logic that we use for somebody trying to lose weight and say, just eat fewer calories, because it doesn't actually work, right? it's why people are drinking the alcohol. Maybe they're depressed. You have to deal with the depression before you can reduce their alcohol intake. Same thing with calories. Calorie excess and weight gain, they're synonymous. One is not the solution to the other. You're trying to figure out what is causing the excess calories, right? And that's where the hormones and insulin plays a huge role, because if you think about what insulin does, insulin is a storage, it's a nutrient sensor, tells your body that, hey, energy is coming in, store some of it. That's its job, right? So if all your energy goes directly into storage, then you're going to be hungry again. So you're going to go get more calories, more energy, more food. So the problem wasn't the calories you took, is that the calories you took were all going into storage because certain foods raise insulin more than others. So there's an overlap there and there's a nuance there, but what we're talking about is the difference between a root cause and a proximate cause, right? Just like the alcohol. We're saying being rich is just a matter of money in versus money out. And anybody who denies that is all wrong. It's not that there's no money. And then saying education has nothing to do with money, therefore it's irrelevant. It's like, no, education sometimes allows you to make more money, right? So it's not that money isn't important, but the education is what's important, or it's the athletic ability, or it's the, salesmanship, or whatever it is. So, calories is this sort of very low first order sort of thinking, right? What we're trying to do is get into the sort of reasons that the calories are in excess of the others, which is why I always say that, thinking about calories is just, it's simplistic and it's not correct, because if you're just thinking about the calories, you're not going to get to the root cause, which means you're not going to be able to solve the problem. Just like with alcohol, right? You can't solve the problem of alcoholism just by saying, drink less alcohol. It's all alcohol in, minus alcohol out. It's the first law of thermodynamics. It doesn't work. Same thing with if you think about why did the Titanic sink, right? People say, well, it hit an iceberg. So the solution is don't hit icebergs. It's like, that's the most useless advice I've ever heard. The solution is to slow down so you don't hit an iceberg, right? It's the same with the calories. If you just say, eat fewer calories, well, you're not getting into the idea of why you're eating those calories, right? So that's the whole thing. You can do a calorie-reduced diet, and some people do it, which is fine, but you're not getting into the reasons they're eating too much in the first place, right? So it's a little bit nuanced, right? Because the whole idea is that if you're taking foods like refined carbohydrates that have a lot of insulin, a lot of those calories are going to go immediately into storage, right? Just like, say you go to Costco. Now you have all this food, but you put it immediately into the freezer. But you have nothing to eat. So what's going to happen? Well, you're going to go out and buy some food, right? Same thing. Say you take 1,000 calories, but you spiked your insulin super high. Well, those 1,000 calories go straight into your fat stores. What's going to happen? Well, you're going to be ravenous soon because you have no energy. So, if you eat white bread and jam in the morning, by 10:30, you're looking for something to eat. So then if you count up the calories you ate in the day, you say, wow, you're eating more calories, right? Because you've gone out, you had your white bread and jam, went into storage. So you went out and got another low-fat muffin, went into storage. So you went, got hungry, ate a big plate of spaghetti at lunchtime, went directly into, those calories went into storage. Then at 2:30, you're looking for some more, oatmeal cookies and granola bars, go straight into storage. Then you count it up and you say, you're eating too many calories. It's like, but why are you eating so many calories? Well, it's because your insulin levels are spiking and you're storing it all, right? So it's a nuance in terms of trying to get into that, deeper understanding of why the calories are in excess. But if you simply control the calories, yes, it can work, because there's studies that have shown that it works. Does it actually work in real life? No, not at all, because people get hungry. Right? You take 800 calories a day, you get hungry. So it doesn't work ever in real life. Don't think we haven't tried it. We've been trying it for like 40 years. We've been telling people to cut their calories for 40 years. Does it work? No, not at all. Theoretically, it will certainly work. There are studies that show that it works.
So it sounds like this isn't something, at least initially, would be a good tool or method to take on. I'm hearing you kind of contrast and give positives and negatives, but in the very end, it seems like because of the hunger piece and maybe underlying issues that aren't being addressed, that this isn't a good method?
If you do it the right way, it can be a good method. If you don't do it the right way, so again, you're exactly right. There's positives and negatives. If you simply cut the fat and eat just carbs that are very low calorie, then it may work. And this is where there's all this debate, right? People go back and forth about, oh, is it calories, is it not? Like, to me, it's already been decided. If the solution was calorie restriction, then we wouldn't have an obesity epidemic. We wouldn't have a diabetes epidemic. If we have the solution in front of us, why would the problem be getting worse and worse and worse over time, right? So to me, weight loss is more about understanding it's more about controlling the hunger, not controlling the calories, right? But it doesn't mean that if you control the hunger, you're going to eat fewer calories. So there's an overlap there that I understand why people get confused. But it's about controlling the hunger, not controlling the calories. That's why Ozempic is ultimately very successful, because it's about controlling the hunger. That's why smoking causes weight loss, because it controls the hunger, and therefore you eat fewer calories. So you have both effects going on, right? Controlling hunger and lowering calories. People debate which one is the most important one. Ultimately, I think it's the root cause is the hunger, and calories is sort of the proximate cause. And you can't treat the proximate cause, right? It's like taking a fever and then taking a cooling blanket. That's fine, but you're not curing any infection, right? If an infection is causing a fever, you can't treat the fever. That's just symptomatic treatment. If you have sort of excessive hunger for whatever reason, which is causing you to eat too many calories, that's eating fewer calories is symptomatic treatment. That's why it doesn't work in the long term, because you have this whole underlying issue that you haven't dealt with, which is the hunger. But if you just simply force people, and again, the studies have been done and they are positive, that's why I bring it up. But it never works in real life, because after 6 months, people just go back to the way they're eating and everything just goes back to the same way. Same as The Biggest Loser, that show that was on for a long time. Nobody ever lost weight long term, like very, very few.
And the other thing that jumps out to me too, as we start cutting calories in the long term, is the impact on the basal metabolic rate.
Yeah, that's very well known. So almost every study in the last 50 years has shown that if you simply follow a calorie-reduced diet, by cutting out fat for the most part, that was the sort of classic strategy for so many years. Your body simply reduces the calorie it burns. So if you eat, and this is the whole thing. People talk about thermodynamics. Anybody who talks about that doesn't really understand what's going on. Imagine that you're eating 2,000 calories, burning 2,000 calories, right? So now you say, I'm going to cut fat. I'm going to take 1,500 calories. Therefore, I'm going to lose weight. It's like, no, you might lose weight or you might not. So if you cut it down to 1,500 calories, every single study we've done in the last sort of 100 years shows that your body will now burn fewer calories. So now you're eating 1,500 and burning 1,500. You're not losing weight. And that has nothing to do with thermodynamics. People say, oh, cut your calories, it's all thermodynamics. You're completely wrong, because if you cut your calories to 1,500 and your body cuts how much it's burning to 1,500, you're still not losing weight. So it's not thermodynamics. That has nothing to do with it. It's about physiology and how your metabolic rate goes down. We know that cutting calories in that situation definitely does, because that wasn't the ultimate cause. It wasn't the root cause. It's about the insulin, right? If you drop your insulin lower, then generally your body, doesn't want to hang on, because insulin tells your body to store more fat, store energy. So if you have less insulin, you're going to store less energy, which is body fat.
Well, let's move into the third tool, which is the best way to drop insulin, intermittent fasting.
Yeah.
So for somebody that wants to adopt this as a method of, again, taking that sugar built up in the body and releasing it, how do they begin?
You can start by cutting out snacks, and then you can gradually lengthen your fasting period to longer and longer. So you can go 16 hours, you can go 18 hours, you can go 24 hours, you can go longer if you wanted to. Because again, if your blood glucose is high, and again, this is in the situation where you're overweight, where it's type 2 diabetes, not type 1 diabetes, as long as you have lots of sugar, then your body has an ample store of energy. So why are you putting more energy into your body when you actually have too much energy? Right? So if you simply don't eat, your body needs to burn that glucose for energy. If it burns the glucose, then that's good, right? You're burning down that sugar bowl. And the thing is that it's very flexible, so you can do whatever you really feel is appropriate. You can do 16 hours, you can do 20 hours, you can do 24 hours, you can do 2 days, you could do 4 days, you could do 7 days. You could, do it sometimes and not do it sometimes. You could do it only when you're gaining weight, right? If you had a vacation and you gain weight, then you can do more. If you're, not if you're at a good weight, then you can do less. So it's sort of infinitely flexible, and really it's a tool that people can use to control their type 2 diabetes, and it's really because fasting means eating zero. And you can't go lower than zero. It's really the most powerful tool that we have. Really, there is no more powerful tool. The question is, how much do you need to do, right? And that's all going to vary. Like, you have to see your own results. If 16.8 does fine for you, then do 16.8. If it's not doing fine for you, do more, right? If twice a week is not enough, you can do 4 days a week, right? You have to individualize it to yourself. There's no sort of one size fits all.
For somebody that may still be hung up on the basal metabolic rate that we were talking about before, let's pull that into the fasting conversation. So for somebody now that is, say, theoretically, they could be eating the same amount of calories as they were before, they're just condensing that eating window and having them within 6 or 8 hours. So talk about basal metabolic rate in that case. And we already went into it on calorie restriction.
Yeah, so basal metabolic rate doesn't tend to go down as much because when you're not eating, when you're fasting, your body actually increases its sympathetic tone. So noradrenaline goes up. So therefore, it's going to keep your metabolic rate relatively preserved compared to simple calorie restriction. So if you look at if you take somebody and you fast them for 4 days, for example, and they've done this study, they measure their metabolic rate before fasting, so at time 0, and then 4 days of zero food, they measure again how many calories they're burning in a day. And it didn't go down, it actually went up by 10%. So your body's actually burning more calories in the fasted state, simply because of these other hormones. So again, if you're keeping your metabolic rate high, and you're trying to lose weight, that's a huge advantage in trying to lose weight compared to calorie restriction, where we know that metabolic rate is going to drift down from 2,000 calories, which you started, and it's going to drift down. And that's how people, I've seen lots of people who have measured their metabolic rate, for example. And a lot of people who have had these yo-yo diets for so many years, they're sitting like 1,000 calories, 1,200 calories a day. It's extremely low. They're cold a lot. They don't have a lot of energy because they're not burning a lot of calories. And the problem is that the way they went about losing the weight, which is cutting down the fat, calorie restriction, their bodies basically shut down along with their caloric restriction. So, and again, there's been multiple studies which show that anytime you decrease calories, just calories, like, the amount of calories that you're going to burn is also going to go down. So you can go very low. Like, if you think you can go down to 1,000, that's very little. It's like very little food. And people say, well, how can you be gaining weight on that little food? It's like, yeah, because their metabolic rate went down even more, right? That's the only way it actually happens. So yeah, that drop in metabolic rate can be very, very severe, and it can be a huge detriment in terms of that. So intermittent fasting is a very good way to keep that up. Same thing with low carb, because you don't necessarily have to restrict calories.
One of the other things I could see people fearing adopting intermittent fasting and having that narrowed eating window is their muscle mass. So for somebody that has listened to some of my other conversations and learned about, and it's everywhere out there on the internet and elsewhere, the importance of muscle mass, especially as we age, for somebody that is fearing that when they're eating within that window, what would you say to them?
Yeah, I there's a few reasons why people get worried about muscle mass, but really it's really overblown, I think, because muscles grow or don't grow based on how much you use them, right? It'd be great if I could just eat and gain muscle. It doesn't work that way. And it doesn't work the opposite either. It's not like you stop eating and your muscles stop, you know, growing, because your muscles respond to how much you're using them. And if you're using them a lot, like lifting weights, they get bigger. And if you're bed bound, that is, you're not even, supporting your weight against gravity, your your muscles weaken very rapidly within, a day or two. You start losing muscle mass extremely quickly. So the whole idea is that what you eat and don't eat is a relatively small contributor to your muscle mass. It's not like your body says, "Oh, okay, well, I'm gonna store energy in the form of glucose in the form of fat, and then when I need it, I'm gonna burn muscle." It's like we'd have to be idiots to do that. Our bodies are just not that stupid. So it's really all about, and part of the problem is that it's all these sort of people who like to measure their muscle mass and lean mass and so on. And what happens is that during fasting, and there was one study that showed this, they took people, they fasted them for 10 days, they measured their muscle mass, and sure enough, their muscle mass went down like, 30% or something scary like that. But when they actually tested muscle strength, it didn't go down, it went up. And it's like, well, how does that happen? And they're like, well, because what's happening is that a lot of the muscle glycogen is being burned off, right? Glycogen is a chain of sugars, and muscle glycogen is not related to the glucose that's in the blood. It's sort of segregated. So as you lose muscle glycogen, you lose muscle water. So then when you measure it with bioimpedance, what you see is a shrinking of muscle. But it's not. It's just the muscle glycogen. So I've had somebody who is super worried about it, for example, and it was is a weird. So he did a fast. He checked his body, his before and after, and what he found supposedly was that his truncal muscles dropped by 10%. So in like a few days, it's like, okay, but he didn't feel any different. Didn't do any more or less exercising, lost, 10% of muscle mass. That's weird. But then when he started eating again and then he redid it, his muscle mass went up, 10%. It's like, so you think your muscle mass went up 10% by not exercising any more or less than you did before, right? How does that work, right? And it's just a difference in muscle water, muscle glycogen that probably explains it. It's the way we're measuring muscle mass and lean mass that is throwing off our thing. And then people, with a little bit of knowledge, they go, wow, it's causing muscle loss. It's like, that makes no sense whatsoever, right? If you think about it, we would have all died long time ago if we lose muscle mass during fasting, because when we're cavemen and cavewomen, there's many times during the winter that people don't have enough to eat. There are probably lots of times they go several days without eating. If every single time you do that, you lose muscle and gain fat, everybody would have lost all their muscle mass like by the time they're like 15 years old, right? They'd just be little blobs of fat running around the American plains, right? Or, the Kalahari Desert and stuff. Those people who routinely fast and feast because of, winter and summer, and if they catch game or don't, they should be little blobs of fat. All these native tribes and stuff that are, in the Amazon that are away from civilization, they should be little blobs of fat, but they're not. They're lean, they're muscular, they're well built, right? Because fasting doesn't really cause muscle loss.
All right, Jason, I know you got to go, but we got to part on this. We got to come back to our underweight person who is suffering with type 2 diabetes. And the three different strategies we went over again are cutting back calories, fasting, and cutting down on carbs, all three of those are going to generally lead to weight loss. So for our person out there who's type 2 diabetic saying, I don't have any weight to lose, how do I go about using these tools without shriveling down to nothing? And I'm curious, as somebody who's in this world, how often you see that?
I see it fairly often, and again, most of the time, people actually have to lose some weight, even though they're normal weight by body mass index. They actually have that abdominal fat that needs to come down, and that's where low carb, intermittent fasting are very effective. Low calorie, again, it's been proven in studies to work, but practically, it doesn't almost ever work in the real world. So even though it can theoretically work, it's relatively hard to do, and I'd say that I almost never see anybody successfully do it using a low calorie diet. But as I said, there's reasons why it's not working well. But for most people who are in that situation, a low carb diet, which is not necessarily calorie reduced, can be very effective. Intermittent fasting, again, can be very effective in those situations too. But most people do wind up losing some weight that they didn't think they had, to lose, but they do. And it's all from the abdominal fat.
All right, Jason, we're going to part ways. This was a great conversation. Really enjoyed it. We're going to link up the Diabetes Code Journal. Congrats on the new book. We're going to link up your social media, your website, everything in the show notes. And I want to thank you again.
Okay, thank you.
Now that you're done here with Dr. Fung, you're going to want to stick around here and catch my chat with Prof. Noakes. He's got a lot to share about the low-carb diet. You don't want to miss this. I'll see you over there.
So for 33 years, I promoted the carbohydrate diet, and it took me to get sick. And when I got sick and felt fat and lazy and couldn't run properly, I was ready.